Hello, 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 everybody. Welcome, welcome, welcome. Tonight, I have something extra special for you. Dr. Goggins is back with us tonight, and we're going to talk about what's going on in the kidney transplant world and a little bit about the new vaccines. So, Dr. William Goggins is a kidney transplant surgeon in Indianapolis, Indiana, and is affiliated with the Indiana University Health Medical Center. He received his medical degree from St. Louis University School of Medicine. He trained in general surgery at the Medical College of Virginia/VUC, and he completed his transplant surgical fellowship at Massachusetts General Hospital. He has been in practice for over 20 years. He specializes in kidney transplant surgery for both adults and pediatric patients. If you remember, he's not only my transplant surgeon, but he also transplanted our little friend, Henry Whitaker, who was 4 years old at the time. In 2018, Dr. Goggins was recognized for performing his 2,000th transplant. From the Indianapolis Star, quote, "There's no doubt Goggins stands out, having notched more kidney transplants than some transplant programs as a whole. Last year, Lutheran Hospital of Fort Wayne did 13 transplants, St. Vincent's Hospital about 50. Goggins might do between 10 and 12 in a week. Ladies and gentlemen, this is the great Dr. William Goggins." Doc, how you doing?
Good, Jim. How are you?
Good, good. It's been a while since we talked.
Yeah. It's been, I think it was the end of March.
End of March.
Yeah.
I wanted to ask you, update us what's going on with kidney transplants at IU Health right now.
Well, after we talked in March, at the beginning of April, we basically shut down completely for about 3 weeks. We weren't really sure what we were going to be faced with. We didn't know how it was going to affect our patients. There were so many unknowns. And then somewhere around the end of April, beginning of May, we started slowly doing deceased donor transplants. And then by June, we were back doing all of our transplants. And in the summer, there wasn't that much COVID going on. It was very minimal. I mean, we now we know it was kind of minimal during that time. We weren't really sure. And it was sort of business as usual, with the caveat that all of our patients needed to know that they need to basically keep themselves quarantined to stay safe, particularly in the early transplant periods when we give a lot of induction immunosuppression. And then in the fall, beginning in October, late September, October, we started to see numbers rise. And then in November, oh my goodness, it's gone through the roof. And in December, we've had probably the most people that we've had in the hospital. And in our hospital system, we've had more deaths in November due to COVID than we had in all of April, which was our previous largest month, and that's all patients. That's not just transplant patients. And so it's been a big difference, and I don't know if it's the fact that we've gotten a little bit of COVID fatigue and people weren't taking the same precautions as they were previously, but something dramatically changed in November. The good news is it looks like it's plateaued now with the amount of new cases. But the hospital systems are still very, very stressed. We haven't stopped doing transplants. We know a whole lot more than we did previously. And what we're really looking at now is ICU bed and ventilator usage to see where we are. And it's split about 50-50 in the state as non-COVID and COVID. And there's about 70% of ventilators still available. At our hospital, University Hospital for the adults, we're basically have tried to stay COVID-free. We do have some COVID patients at university, but the vast majority of COVID patients are taken care of at Methodist, and then Eskenazi is a really full as well with COVID. So we're sort of playing it by ear and just sort of following what's happening. It looks as though the trends are stabilizing, and so we're still transplanting. And actually, we've done more kidney transplants this year than we've ever done, which is amazing. Taking the time off, the most we had done in a year is about 246 last year. We're about 286. Wow. We're almost 300 this year.
Congratulations.
Yeah.
I read in the news yesterday that the governor of Indiana has suspended all elective surgeries or asked the hospitals to postpone non-emergency type surgeries. Has that had any effect on you as a transplant surgeon at IU?
It hasn't. Well, earlier in the year when we weren't sure what we were dealing with, we definitely stopped everything. Now, as a program, as a hospital system, definitely straight up anything that's truly elective is not being done. And I think then when you're looking at sort of urgent elective stuff, we're looking more at who has the potential to require ICU stay and to be on a mechanical ventilation. And in those particular cases, I think people are shying away from that. So, for example, if I had, as a transplant surgeon, we take on some very sick people and some high-risk patients. Currently, if I had a patient that I knew had a lot of pulmonary issues and most likely was going to end up in the ICU, I probably would tell them, hey, let's put this off for a little bit and let's not go ahead, knowing that the capacities for the intensive care units could be taxed. But for your straightforward kidney transplants, the vast majority of my patients never see at the ICU, or if they do, it's only for 24 hours, 48 hours, if that. So for me, it's more of these patients that we know are going to require a longer ICU stay that we're sort of trying to put those people off. But in general, I think we're still sort of open for business and not changing too much.
Okay. Have people with kidney disease been severely affected by COVID-19? Higher rates of infection, critical illness, sometimes death. Have you seen this in your practice?
Yeah, I mean, people with chronic disease processes are more susceptible to severe COVID. I don't know if they're necessarily more susceptible to get COVID. I think that's sort of a general population issue. However, if they do get COVID, COVID, they tend to have much more severe disease. And there's some papers that showed that renal failure patients in and of themselves, people on dialysis, had a higher mortality rate, as well as transplant patients. There's one study that had a very small amount of kidney transplants, and they said that 6 out of 7 of them died. That's not the case. We have had, as of last Friday, there were 166 kidney and kidney pancreas recipients that had COVID in our institution, and we had 9 deaths, 3 of which were kidney pancreases that happened within the last week. So our death rate for straight kidneys is good. I mean, it's higher than the regular population. However, I think that it's not hard. If you're a kidney recipient, you get COVID. It's not a death sentence, right? So because we have so many people that have survived, and really, I think it comes down to how severe your issue is and how quickly you get to the hospital and get treated. We still are trying to treat a ton of our patients as outpatients, but if they end up having lower oxygen saturations, that's when they end up coming in like the regular patients. And really, at our hospital system, the liver transplant recipients and the lung transplant recipients have a much higher mortality, and that sort of makes sense with the lung recipients in COVID.
Okay. It's my understanding that the Indiana School of Medicine has been conducting COVID-19 vaccine clinical trial studies. You had about 3,000 volunteers, including minority groups, in that. Are you familiar with that? Can you talk a little bit about what's going on?
I know that trial was the Oxford vaccine trial, which was the AZT1222. And actually, one of my nephrologists that I work with, Dr. Sharfudin's in that trial, where they're randomizing people. I think it's been halted. I'm not 100% sure. I know it was going on since September, but I believe it's been halted now. I think because the emergency release of the Pfizer vaccine. But my Dr. Sharfudin is pretty convinced that he actually got the vaccine because he had symptoms. So,
okay.
But yeah, there's been an awful lot going on prior to this with people volunteering, and one of my nurse practitioners, Tony, whose sensation was in a trial as well. I think the same trial, and he said he didn't have any symptoms, so we don't think he actually got the vaccine.
Wow.
So,
excellent.
Yeah.
Excellent. It's my understanding that last Friday the medical school was actually conducting rehearsals for procedures administering Pfizer's COVID-19 vaccine, with the anticipation that they would begin inoculating patients this week. Can you tell us a little bit about the dry run that they were doing down at IU?
I saw that as well, and I think what they basically were trying to do is make sure all the systems were working well. This vaccine has to be at a very cold temperature, minus 70, minus 80, to be stable. Messenger RNA, which is this vaccine is made from, is incredibly unstable at warmer temperatures. And so you have to keep it really cold. And one of the other things I do is I'm the interim director of the HLA lab as well. And we were asked if we had extra minus 70 freezer space for vaccines to be able to store the vaccines. One of the reasons why they set up this mock drill is to make sure that nothing really goes wrong, to see if they can find weaknesses in and how everything is done. And actually, I thought it was a really smart idea, so that nothing, or you can try to eliminate the possibility of something bad going on where you might end up losing vaccine. And one of the reasons why they have healthcare workers setting up for appointments is that these vaccines have to be thought in a specific way in a certain period of time when you're going to get the vaccine. So by having it scheduled, they know when they can start to thaw the vaccine and when they're ready to administer it. So it's kind of tricky, particularly with the Pfizer vaccine. And the Moderna vaccine, I believe, is more stable at a lower temperature and can be in the refrigerator for like 30 days or something like that. And then some of these other vaccines that are starting or in process might be more stable at room temperature. But certainly this particular vaccine needs to be at -7, -80 to keep stability.
Yeah, and I understand that the 975 doses they ship to IU, they're basically coming in packaged freezers when they show up, and then you have to have the space, of course, to put them somewhere.
Yeah, that's exactly true. I think they're coming out of Michigan. I think they were
Portage,
delivered
Michigan.
yeah, and so my sense is that they're packaging, and I know someone in the packaging business they've been asked to try to develop packaging where they can have the dry ice and keep these things cold, and it's really tricky, and it's a very difficult design for these packages to make sure that they stay cold. So implementing it and getting them through, it really is exceptional how they're able to do this.
Okay. The FDA used its emergency powers to approve this vaccine. Can you tell us why did the FDA use its emergency powers to approve the two vaccines that we're talking about, the Pfizer vaccine and the other?
Yeah, I know that they approved the Pfizer vaccine for emergency use because of the results being so well in the trial that they had with the 44,000 people, but also because because of the face of this pandemic and where they're having to try to inoculate people. So it's emergency power. It's not the true FDA approval. It's a different aspect. So if they want to get true FDA approval, I believe they have to resubmit things. But this is sort of for emergency use because of the pandemic and all the death and disease associated with it. And just because they ended up having emergency approval, I think there is a misconception that that this vaccine was either rushed or corners were cut or anything else like that, and that's not the case. I think by speeding up the process with this warp speed, I think it just eliminated some of the barriers, some of the built-in downtime, some of the they can have up to a month to review things, so they take away that, and so they have to get the data and review it in a shorter period of time. So that's how this process has been sped up by eliminating some of the built-in delays. But the testing and the overall data that has come through to the FDA to be able to approve this drug has been rigorous. And so I don't think the concern, because it's come out so quickly, the concern that it hasn't been tested anything, I think that's not the case, and people should not be thinking that.
I understand that Indiana is going to get 55,575 of the Pfizer vaccine initially, and that the Moderna will follow in the coming weeks. Where in Indiana will the vaccine be delivered? Do you know?
Well, there's like 50 hospitals that are going to be on the list, and I believe the first doses were given either Sunday or Monday in Fort Wayne at Parkview. And then there's a bunch of hospitals that have already started being able to give it. And so, for example, I got an email on Saturday telling me that because I'm an essential healthcare worker, that I can sign up to get the vaccine. And you can sign up for your Northern Indiana, Central Indiana, Southern Indiana, and there's a whole bunch of hospitals that you work with. And so there's just the hospitals that you can think of on the list. So you click into that and you get your time and your ability to get vaccinated. So it's all over the place. And I know that the IU system is going to be starting on Friday.
Friday, okay.
Yeah.
I have read the first 5 hospitals to get the doses. Community Hospital in Munster, which is just like over the bridge from me, a couple of miles. Clark Hospital in Jeffersonville. Deaconess in Evansville. Of course, IU Health Methodist Hospital in Indianapolis, and you mentioned Parkview in Fort Wayne. We're talking about maybe 50 hospitals by the end of the week?
Yeah, I don't know if they're all gonna start by the end of the week, but I know that uh, um, when I looked at signing up in different places, they gave you specific days, all within probably 7 days. So I'm sure there are some places that are going to be like we're starting Friday, but I'm sure there are other hospital systems that are already started a day earlier, depending on when they're getting drug in and have it all set to go. And for IU, it's the first doses are on Friday.
Okay.
So, yeah.
I've read that once the vaccine gets rolling, that as an individual, I can get it at places like a pharmacy, nursing home, public clinic, hospital, doctor's offices, mobile clinics, and military facilities. Do I need a doctor's order to get the vaccine?
Well, this is going to be rolled out in phases, and I don't know if I'm assuming that you're going to need to get a doctor's order, but it may be like when you go to CVS to get your flu shot. You don't necessarily need a doctor's order, but I don't know if they're going to require that or not. My sense is that I just don't know. I haven't heard whether or not we're going to have to prescribe it for our kidney transplant patients or not, and maybe I missed that. All I know is that like I don't need a doctor's order. I just signed up to get it because I'm an essential healthcare worker. So I'm assuming that people are going to be able to just sign up and get it without a doctor's order, but I'm not 100% sure regarding that.
As opposed to a normal vaccine, this vaccine was made from synthetic materials. Can you talk a little bit about that, please?
Sure. This vaccine and the Moderna vaccine are made synthetically against messenger RNA. This is really super cool technology. The development of mRNA vaccines began in like 1990. So this is like 30-year technology. And they first started using messenger RNA in like rats to develop certain proteins for them. So Pfizer, they had people that were already working on different messenger RNA vaccines. And when the genetic code for COVID was put out in January, I believe, mid-January, within 2 months, they had codes for messenger RNA, genetic codes for messenger RNA that they were working with. And so what messenger RNA is, it's not DNA because it's RNA. And the messenger RNA is a signal within the cell that tells the cell to make a certain protein. So this particular messenger RNA is to a unique protein on the COVID, which is called the spike protein. And so the neat thing about a messenger RNA vaccine, and this is the first FDA-approved messenger RNA vaccine that's completely approved. There are other mRNA vaccines that were in development for SARS and MERS, but because sort of SARS went away and MERS didn't really happen, they sort of fell by the wayside. What happens is you get the injection of the messenger RNA into your muscle, and then your body, it tricks your body into making the spike protein. And so when your body makes it, all of a sudden it recognizes the spike protein as being foreign. It's probably processed and put on MHC so that the body recognizes it as foreign. And then you develop both a cellular response and a B cell or an antibody response. So it's really kind of neat technology on how they developed it. And unlike a live virus or something else, you can't get COVID from this virus. It's just a messenger signal to make a protein. So it's not going to it's not going to give you COVID, and you're not going to be able to give anybody COVID. So it's not like a live MMR virus where you actually get the virus and you're starting to spill virus when you get infected and you can infect people. This is a completely synthetic and non-infectious way to do the virus. It's really kind of neat.
Okay. Is the vaccine safe?
Oh yeah.
Would you consider it safe for like your wife, your children, for example?
Yeah, I mean, I signed up for it. So I'm going to be getting mine Friday at 4:10. So if I was concerned that it was unsafe, I wouldn't be doing it. So yeah, I think that the side effects are usually sort of a typical sort of viralish side effect. You get fever, malaise, joint pain, and it seems that in this particular situation that the second dose is worse than the first, so that you can experience more symptoms at that point. But I don't think there's any data in the preclinical trials or with the 44,000 people that were in the trial, or 22,000 that got it, that there were that it was unsafe. Now, they do say that people that can have a sort of a strong allergic response, that they should be cautioned. I'm assuming that because this is waking up your immune system, particularly to something that's completely foreign. If you have sort of a like bad allergies, or you're allergic to everything, including mold, cat hair, dogs, everything, I think those are the people that might have experienced more intense symptoms. But I don't believe there's any contraindication for any patient population to get the vaccine.
Okay, we talked about the vaccine being safe and the vaccine being efficient. How well does these vaccines from Pfizer and Moderna, how well do they work? What kind of results can you expect?
Well, in the trials, they have after the second dose, they've had 95% effectiveness in developing antibody. There was a question just came by about how do I feel about getting the vaccine. I don't like the idea of having like flu-like symptoms for a little bit of time, but I think overall, I think the benefits of getting it is far outweigh the risks. And we have our mother-in-law living with us; she's 85 years old, and I'm basically getting vaccinated for her, so that I don't have the possibility of getting infected and unknowingly getting her infected. So I think that, and I take care of transplant patients all the time, and so I don't want to worry about getting my patients infected if I get infected.
Okay.
So that's the reason why I don't think that the data on, I don't think that as far as the vaccine affecting transplantation, I haven't seen any data, because this is an mRNA to a specific spike protein. I don't believe that there's going to be any HLA sensitization. So I don't think it's going to cause people to develop antibodies towards HLA. Some other vaccines that are built using sort of human DNA constructs and stuff like that, and so they can sometimes have human markers or MHC on it that you can get sensitized. That's happened previously in some other vaccines, but I don't believe, because this is a synthetic and against mRNA, I don't believe that this is going to cause a antibody response, an HLA antibody response.
Okay, so the vaccine isn't going to prevent you from doing kidney transplants?
No. I mean, maybe, yeah. Even if I felt, I would probably just take some ibuprofen and transplant anyway. If I was feeling achy or something. So I don't think it would stop me from doing any transplants. So.
Okay. Should a patient, let's talk about kidney patients and kidney transplant patients, should they consult with their doctors before taking the vaccine?
Yeah, I think before you do anything, it's a good idea to talk to your doctor specifically about if you're going to entertain into something that could cause you to have some side effects of, you don't want to call your doctor up specifically as a transplant patient saying you have chills and joint pain, and aches all over. You're going to freak them out thinking that, you might have some other virus. So I think that in general, I as a transplant community, we're going to be very supportive of getting our patients vaccinated, both pre and post transplant. So I think that, like in general, before you consider anything, you should be talking to your nephrologist or your doctor.
Okay,
so that's always a smart idea.
How many doses of the vaccine, the Pfizer vaccine and the Moderna vaccines, do we need to take? Is it a single dose thing? Is it a double dose thing? How would you characterize it?
At present, it's 2 doses. The Pfizer is 2 doses, 21 days apart, and the Moderna is 2 doses, 28 days apart. And to be able to produce the 95%. Now, I'm sure there are a number of people. I didn't look at the actual study to know how many people had effectiveness with the single dose. It may have been 50% or 60%, but the second dose gets you to 95%. That's the same way, you do the same way the kids get the 2 doses of the MMR. It takes 2 doses of the MMR vaccine to get you to 95% as well. So the fact that you need 2 doses is not unexpected when you're doing vaccination. So.
Okay. Doc, I'm terrible with dates. What happens if I don't get the second shot on time? Do I have to start over? Is it okay? What occurs?
I believe that you don't have to start over. You just have to get the second shot. The second shot, as soon as you can if you missed the date. And that's really to help with the immune system. Once the immune system sees the first dose, the second shot should be hopefully on schedule. However, if you don't get the shot specifically on time, if you get it within a reasonable period of time or even not, you're probably going to get the same benefit because of the immune system. I think that they're basically saying 21 days or 28 days. But that's what they did in the study. But it's not one of those things that I believe you're going to have to start over at all. I think just, if you forgot, get it as soon as you can.
Okay. In terms of the order, what is the order that people are going to get the vaccine, both throughout the United States and here in Indiana and at IU Health?
So the phase 1A is healthcare workers, right? So it's frontline people that are dealing with COVID patients or patients that are at high risk for COVID. So it's going to be your doctors, nurses, medical students that are taking care of the patients. And I think there's 55,000, somewhere around that for the primary 1A. 1B, the second part of phase 1 is going to be essential workers and people with high-risk medical conditions and adults over the age of 65. So that's when more of your higher-risk people, the over 65 patients, and people like high-risk medical conditions, transplant patients, liver failure patients,
kidney failure patients.
Yeah, people. These are high risk. I mean, also I think probably hypertension is going to be included in that as well because they're high risk for having severe problems with COVID as well. So I don't know if they've been clearly defined, but certainly I think if you have high risk medical conditions and being immunosuppressed or people that have difficulty with COVID, which is renal failure patients, I would include in that. So if you were one of my patients, I would be pushing to get you the vaccine in the phase 1B issue.
Okay. As I understand it, you have to be at least 16 to get the vaccine. Is that correct?
Yeah, it's not approved for under 16 years of age. I'm not clear 100% why that is, but really under 18 patients. They don't tend to have a lot of issues with COVID. You see some stories, every once in a while that a pediatric patient has a problem, but the ultra vast majority of the younger patients, they have either asymptomatic disease or very minimal symptoms. So I think, plus when you're dealing with immunization of pediatric patients, I think there's a different set of testing that you have to do. So adult over 16 or adult vaccines, I think they all fall into the same situation. And that may be the reason why they're excluding younger patients. I don't think they have had enough time to look at the data. But yes, under 16 is not included with the vaccine.
Okay. I have been reading, and I saw that maybe by the summer of 2021, they might start vaccinating children right before they go back to school. That's a possibility. Our friend Bruce is asking, what about cost? How much does the vaccine cost?
Well, the government's going to pay for the vaccine. So it's not going to cost people any money to get the vaccine. Um, I had to supply my insurance information because I think they're going to try to build the insurance for whatever they're going to give for a vaccine, but there's going to be no out-of-pocket costs for people. So I think that if you're going to get the vaccine, you're going to get it for free. And if you don't have insurance, you're going to still get it for free. But I think that they're going to try to build insurance to see if they can recoup anything for it. And I don't know if the vaccine may say, if the government's going to give it for free, we're not going to get anything for it. But it's not going to cost people money to get it. So I think it's going to be free in everybody's area.
Okay. Would you agree or disagree? Realistically, we're talking about healthcare workers, nursing home personnel, getting their vaccine, completing it January or February of next year. Would that be a fair statement?
Yeah, I think that's what they're looking to get into phase 1B in January, February. So I think that they're hoping to get the phase 1A done with by the beginning of January, and then go into essential workers, people with health conditions and over 65 hopefully by February.
Okay, so we're talking about the rest of us beginning in April and May and sometime after that. Is that correct?
Yeah, I think if you're under 65, otherwise healthy, don't have it, you're a regular person. I think you're looking at the summer. It may be early summer, maybe late summer. It's hard to know. I think it also depends on, ramping up production to be able to, one, get enough vaccines out, whether or not the Johnson & Johnson vaccine, when the Moderna comes out, and these other vaccines, if they show effectiveness. I think if we end up having 3 or 4 vaccines, I think the vaccination of the general population is going to go so much faster. And then, once we get, so many people vaccinated, then we're looking good at returning to quote unquote sort of more normal activity. But in the near future, people ask, oh, if I get vaccinated, am I going to be able to not wear a mask anymore? And I don't think that that's necessarily going to be the case. I think that once people, I think what's going to, so the question is, how are we going to know when things are so much better that we are looking that we can return to more normal activity and maybe go to a baseball game, or go out and spend some time or in larger groups of people, go to the
restaurant,
go to a restaurant and sit down and with more than 2 people. I think it's going to be dictated by how many people get vaccinated, and then looking at the absolute numbers of infections. So just as we've seen in the last month and a half, the infections go through the roof and the positive test rates go through the roof, what we'll see is all of a sudden these test rates, positivity rates are going to start to go down, hospital census is going to start to go down, the amount of people that are getting tested is going to go down because of the vaccination and getting more people through the process. So once you start seeing the trends go way down and staying down for a period of time, maybe it's going to be a month, maybe it's going to be 2 months, maybe it's going to be 3 months. But once you show that there's a significant reduction and a durable response, so that you're not having these rebounds, then I think you're going to see people being able to go back to more normal. But I have a feeling that people are going to be a little slow at present, just because we're going to a big unknown. And we know that people that get COVID and they develop an antibody response, within 3 to 6 months, their antibodies go away. So does that mean they're going to be able to get infected again and have a big bad problem? It's unknown. I don't think the immune system works that way. I think that if the antibodies go away and you do get another infection, say you get a different strain, but you might start to feel ill for a day or 2, but then your body's going to have an amnestic response and develop antibodies very rapidly. So probably before you even get to the point where you would be infectious, your body's already going to be developing antibodies and going after the new infection. So So I think that with either having COVID or getting vaccinated, I think the risk of spreading it is going to be, if you get reinfected, is going to be super low. I don't think it's known yet whether or not that can happen, but the way the immune system works is once you have antibodies, you're either going to have durable antibody response, which I don't think in this COVID case it's going to be, but you have what's called an amnestic response, so that once you get re-stimulated with the antigen, your body antibodies very, very quickly, so that you're going to end up having, almost no discernible symptoms, and it'll kick in. Whether you might have an hour or two that you might shed virus, I don't know. I don't think that data's out there yet, or we're going to enter that. And I think that's why people are going to be very conservative in letting people go without masks and stuff like that early on, because we just don't know. We know there's an immune response. We know you develop antibodies, but what's going to happen once you get re-challenged? Is it going to be a problem? So I think that I would certainly say even after I get vaccinated, I'm still going to be wearing a mask in the hospital. And if I'm around other people going outside, going to the store, I'm not going to get a pin saying I've been vaccinated. I'm not wearing a mask. That's not helpful. That's not the way it's going to happen. So even though I'm going to end up getting vaccinated, I'm still going to be wearing a mask for the foreseeable future until we have good, strong data to show that it's safe. And that's going to take time. And once enough time passes, we have some good data, then we'll know how long after you get vaccinated, when when the mask can come off, and when we can resume normal activity. But it's it's really, I mean, this is unknown territory, and doing stuff that was, it's like Star Trek, right? We'll be going where no one's gone before. So,
Right.
It's a learning process, and I think that the key is to have everything as open as possible, so the data can be seen, and people can see what's happening with the trials and what's happening with people.
Okay. Should a kidney patient or a kidney transplant patient get vaccinated if they've already had the coronavirus?
At present, they're telling people that have had coronavirus in the last 3 months not to get vaccinated. I'm unsure if I had COVID or not back in the springtime. I never was tested, but I got really sick and I lost my sense of taste and smell, and was horribly sick, about as sick as I've ever been. And I'm getting vaccinated. So I think, I think that they're going to have people that, if you haven't had in the last 3 months, I think they're going to allow people to get vaccinated. So I think that's something. Now, I think natural immunity is probably going to be better, and that if you had COVID, your body has seen the entire COVID, not just a little piece of a spike protein. So in general, I think natural immunity is better than vaccination if you've had it. But this is a virus that the human species hasn't seen before. So what's the best way to attack it? I don't know. But I think if you have lost your antibody response after 3 months, getting a vaccination is not going to hurt you. And we get the flu vaccine every year. It's not really, I don't know if you call it a vaccine, but the flu shot every year. And it probably has some of the same markers, just mixed up. And you get a tetanus shot to try to get antibodies towards tetanus. And people get that multiple times as well. So I think that if you had it, you're certainly not going to be in the first in line to get the vaccine. And if you haven't had it in 3 months, that people are still going to be able to get vaccinated.
Okay. I have read the goal is to immunize about 120 million people with 2 doses through the first quarter of 2021. And that in order to achieve this herd immunity that you've been talking about 60 to 70% of us have to have the vaccine. Once we have achieved that point of herd immunity, do we have to continue to wear a mask, social distance, wash our hands, use hand sanitizer, or is the idea that hopefully this will be behind us?
Well, I think that, boy, it's hard to know when this virus, if 60% is going to be enough. I mean, certainly with measles, you need a 90+% vaccination rate to get herd immunity. With polio, you needed 80+% vaccination rate to get herd immunity. With this being, I would be a little bit concerned that you need more, closer to 80% to get sort of a herd immunity. And sort of herd immunity is sort of, the general population has antibodies, so the risk of getting it drops dramatically. I think that once we get to a certain percentage of patients that have been immunized, I don't think that we're going to be able to just stop wearing masks and taking all the precautions. I think what's going to end up happening is you're going to have to look at what the actual infectious rate is in the state and see what's happening, and then stepwise take away restrictions and see if letting more people gather, having things close together, does that make the cases pop like it has? Like when when the state started to open up again, also the cases started coming back up, or not? And if it doesn't, if you don't see an increase after you've been a certain percentage has been immunized and you have quote unquote herd immunity, then I think that you're going to be able to take your masks off at that point. So it's going to have to be a stepwise fashion. But I don't think just because we've vaccinated 61% of the population, now everything can go away. I don't think that's going to happen. I think you're on your way, but I don't think it's not going to be like a light switch where all of a sudden we can just take things off.
Do you foresee a time when we'll actually have a choice of vaccine, or is it going to be catch as catch can? You have to use what's available.
In the short term, it's just going to be whatever is available. I think once these other vaccines become available, it's possible that maybe by the end of the summer, there'll be extra vaccine around. You'll be able to ask for it. But I think the demand is going to be such that there's going to be limited supply, and if you want a vaccine, you're going to get X, you're going to get Y, and you don't get a choice. And really, they should all be pretty close to almost identical in what they do. So other than 21 days or 28 days, you need a second shot. Now, I think Johnson & Johnson vaccine, they might be just looking at a single shot,
single shot, right?
Yeah. So, I mean, it's quite possible that if that's the case, there may be more vaccine available because you only have to get one dose rather than two doses. So it's possible by the summer, late summer, maybe you'll have a choice of which one you're going to want to take. And I'm going to bet you people are going to say, give me the one that I only need one shot.
Great. Should we be concerned if other people decide not to vaccinate? And if we should be, why?
Well, I think that if you have people that aren't vaccinated, they're going to continue to be at risk of getting the vaccination is, that's a personal decision that everybody has to make. And it's not going to be something that's going to be mandated, at least at present. It's not something that's going to be mandated. But I think that if you're looking at getting vaccinated with a very low risk of any possibility of a significant sequelae from the vaccination, I think that everybody should be urged to really consider doing it and doing it. There are going to be some people that aren't going to vaccinate, but they're going to put other people at risk still, until the vast majority of people have been vaccinated. So I think going on early, it's going to be, it's like the same thing is if people, they don't believe COVID is a real thing and they end up getting sick and they end up going all over the place and infecting other people. I think the more people that get vaccinated, the risk of somebody not getting vaccinated goes down dramatically. But at present, the risk of not getting vaccinated is still a significant problem. It's possible that once you get herd immunity, the chance of getting COVID goes down so dramatically that you don't end up having to be vaccinated. And we also don't know, as young people get older, that never had COVID, didn't get exposed, in 10 years, Are they going to have to get vaccinated against COVID? Is this going to be an ongoing problem, or are we done with it once we go through it one time or twice? I don't know, a couple years. I think that remains to be seen. Certainly, I think because this is such a novel virus, it's going to take, some people think, maybe 3 years to get completely through the population. And that was before vaccines came, so maybe it'll be shortened dramatically, so that the risk to the population goes down. And in general, as a new virus goes through the population, it loses its effectiveness against the population because it changes. And hopefully that'll happen with this virus as well. I know there's multiple strains of the virus now, and we're still seeing people get super sick, but I don't know. Sometimes it appears that the virus is more infectious now, but not as lethal. But we just had more people die in our hospital system in December than in April. So it's hard to know. Is it just that we have so many more people getting COVID that there are more deaths because we have such a higher population of people getting it, or is it still a very virulent virus that some people just are? It's a really, really bad problem, as opposed to just a bad problem.
Okay, let's talk about the myths that are floating around out there about the COVID-19 vaccines. Does the COVID-19 vaccine affect your DNA?
No.
Does it mess your DNA up? Our friend Denise is asking.
No, it's a messenger RNA, which is a signal to produce protein. It's not a retrovirus. It doesn't intercalate into the DNA. It's not part of a cell replication. So it's once it builds the protein, it disappears. So it's not something that's going to go into your DNA or change your genome or anything like that. That's a myth.
Okay, what about pregnant women who are breastfeeding? Can they be vaccinated? Is there a problem with that?
At present, they're excluded from the trials because I don't think people know exactly what's going to happen. Pregnant women have gotten COVID, and there's some percentage of pregnant women that seem to have a more significant disease, but there's also kids that have been born with COVID at the time. So I think at present, pregnant women have been excluded from the trials. There's certainly myths about the vaccine that can cause sterility or whatever, and that seems to be a myth as well. And that's sort of based on a certain protein that's made in the placenta that the spike protein shares a small amount of repeated sequences. So it's like if you were reading a book and they mentioned a white whale, that doesn't mean it's the book's Moby Dick. It's just that it just happened to mention two specific things that are similar, but it's certainly not it's not the same thing. So so it doesn't. So I think the chances of that being a big problem are super low.
So it doesn't cause sterility. It doesn't cause miscarriages. Best bet for a pregnant woman or someone who's breastfeeding, check with your obstetrician or your pediatrician first.
Yeah, and I think the actual disease COVID just was associated with earlier birth, like at 37 weeks rather than 40 weeks. And that's the infection. That's not the vaccine. So I think that certainly once we get to the point where, there were articles out in August and September trying to get women who are actually pregnant in these trials to see what would happen, but that hasn't happened. And so I'm sure that in the future they may look at that, but at present, I think if you're pregnant or considering being pregnant, you're going to need to talk to your obstetrician.
Okay. You've talked to us a little bit about people with allergies, people that have had bad reactions before, anaphylactic shock, for example. Can you talk to us a little bit about that? Should those people with bad allergies or have had bad reactions in the past take the virus shot?
Well, I think that those people should be very concerned about taking the vaccine at present. And I know that when I signed up for it, it asked me specifically if I had a severe allergic reaction. So I don't know if those patients that say you're a high-risk patient and that you need to get the vaccine, I don't know if there's going to be a pre-medication protocol, like for people like say they're allergic to contrast, you give them prednisone or whatever to eliminate it. But at present, I think they're shying away from giving patients that have a strong allergic reaction to the vaccine at present. I think they need more experience with those types of patients to see what they can do. I know that they've had some severe reactions with those particular type of patients. And I don't know if they're being excluded. When I get my shot on Friday, I'm going to ask to see because I don't know the answer.
Okay. One of our viewers is asking about the artificial kidney. Do you have any idea where we're at with that? What's happening?
Well, I know that that's been on the horizon for a while, and there's been some interesting data about artificial kidneys, and they say they're going to put me out of business in a year or two. Good luck. I don't know. They're one of the problems with the fact that the pandemic has come is it's basically shut down all research that's not related to COVID. So I think that they're going to be still opening that stuff back up, and we couldn't even enter into new clinical trials of different medications, and we had to stop what we were doing for a little bit before we entered patients into other trials that we had ongoing. So I think certainly if you're looking, we had some people that I work with were looking at getting NIH funding, and nothing's being funded unless it's COVID related at present. So I'm not sure what's going to happen with the artificial kidney. Some of the early data seems promising, but I would be surprised if they put me out of business.
Nah, don't worry, Doc. They're just going to have you putting in the plug. Won't be the real kidney, be the artificial one. We need Dr. Goggins to do that for us.
Yeah, we'll see.
Is there anything that has to do with kidney transplant or the vaccine that I haven't asked you about or that we haven't discussed that maybe we should have?
I think that there's always questions about what's going to happen if I take the vaccine in 10 years from now, or long-term consequences of the vaccine. I don't, the vast majority of the time with this type of vaccine, I think that because it's a messenger RNA, that the chances of a long-term problem from the vaccine is going to be super low or non-existent. And I think that, I think once you vaccinate 5 million people, there may be some weird thing that pops up or that you couldn't predict. But I think with the way it looks and how it was developed and the specific protein it's developing, I think those risks are really small. And like if you have an allergy to eggs, you're not supposed to get the flu shot. Okay, so that's one of the things that maybe we'll find out. Certain people that they shouldn't get it because they get such a strong response. But I think when you're looking at a virus that has the problems of this magnitude, not only here but worldwide, and how many people have died from it, and it's ongoing, I think that getting this virus from the last January when they first sequenced the virus itself, have an mRNA vaccine that's never been FDA approved out and injected into people clinically in under a year is mind blowing. I think it's a testament to the system, the fact that the administration really streamlined things to get the FDA working in a more efficient fashion, working with industry. And I really, I think that everybody involved should take credit for doing such a wonderful job to get this to people, because when they were first talking about vaccines back in March, they were talking 3 years. They were talking mRNA vaccines not going to happen. It's going to be 3 years. It's going to be it's impossible. Blah blah blah. All this stuff, and it's truly amazing. And this time that we're living with the technology and the ability to sequence certain mRNA fragments in the technology, it's remarkable.
Okay, I just wanted to remark the two vaccines that they're talking about that are currently out or about to be out are 95% effective. The flu vaccine that everybody takes, only 50%.
Yeah, it's a crapshoot. Yeah, it's 40 to 60%. If they're really good at trying to figure it out, you might get 50-60% effectiveness. So this is really a specific protein that's made by this specific virus that you develop an immune response to, the spike protein, and so that's why it's so effective, and it's amazing. So. Okay,
Dr. Goggins, I can't thank you enough for taking time to come on and speak with us tonight. Appreciate it very, very much. I learned a lot. To our audience out there, I've got Christmas and New Year's, the last Friday in December, the first Friday in January off for obvious reasons, but I'll see you again the last Friday in January. I think that's the 29th. The great Valen Kiefer is going to be with us on that date. So double transplant, a patient, excellent kidney advocate, excellent PKD advocate. Don't miss that broadcast. I will be writing in the meantime, so you look for my blogs, and I appreciate you taking time to stop in and give us a listen tonight. Thanks, everybody. Good night.
Good talking with Jim.
Good talking with you, Doc.